Now, moderating this last panel, and I have the great honor and privilege of introducing her today, Miss Elaine Reid. And I think, yes. And I think I speak for all of the BSW alumnus in the room that Professor Reid has definitely made an impact on the BSW program here at Medgar. And although she is a retired assistant professor here at Medgar, she will always be Professor Reid in our eyes, right? So Elaine Reid is a licensed clinical social worker and a retired assistant professor here from Medgar Evers College. She holds a Bachelor's of Science in Human Services from Hofstra University, a paralegal certificate from Adelphi University, and a Master's in Social Work from Hunter College of Social Work. She also holds a certificate in field instruction from Hunter College. And on top of her 30-plus years of experience in the social work field, she's also the co-founder of the Caribbean American Social Workers Association. Let's give a round of applause for Ms. Reid.
Good afternoon, everyone. It's my pleasure to be here. Thanks, Malik, again for inviting me and putting me to work, as always. And the beauty about going last is a lot of the discussion is, happened before, so you can build on those. But the bad thing also is you go behind some powerful people. Dr. Pryor, who I worked with years ago in HIV/AIDS, I used to call him Divine then. Now I have to call him Dr. Pryor. But it was a powerful, all the presentations, all the panelists, it was very powerful. I learned a lot from that. So let me read my panelist's bio, and I'll just skim through some of it. I'm not going to read the entire thing. So Seanna Kaye Denham-Wilks, Dr. Seanna Kaye Denham-Wilks is an accomplished visionary, clinical psychologist, and the Chief Experience Officer at New York City Health and Hospitals Corporation, Kings County Hospital in Brooklyn. She directs the hospital's patient experience and employee engagement activities based on transformation and person-centered approaches, and is nationally recognized for her work in this space. The next panelist is Dr. Mathylde Frontus. She's a Brooklyn native and currently serves as the interim Executive Director for the Coney Island Neighborhood Revitalization Corporation. She has a distinguished social work career spanning over 25 years, during which time she's held various positions as a case manager, mental health clinician, medical social worker, nonprofit executive director, community organizer, and founder of multiple coalitions and organizations. She is a former member of New York State Assembly. Okay, and last but not least is Kelsey Louie. He is a native New Yorker and the proud son of immigrant parents. Kelsey Louie serves as the Chief Executive Officer of the Door and Broome Street Academy Charter School. He oversees the organization's combined $40 million budget, as well as the vision for strategy, operations, fundraising, policy, and programmatic initiatives. Please welcome Mr. Kelsey, Dr. Wilks, and Dr. Frontus. So the panel that I will be moderating is Inequities in healthcare, re-traumatization as an implication of healthcare service delivery. In the discussion, we talked about trauma-focused care and trauma-focused and trauma-informed care. So in trauma-informed care, we not only identify what has happened, but how is the patient or the client addressing the trauma that they've experienced. We know that trauma is something that is very difficult, and it's hard for us to really overcome some of the experiences that have traumatized us over the years, over time. And so we as social workers have to really try to be mindful when we're working with clients who have experienced trauma and use our social work skills, empathy, our understanding. Again, someone talked about eye contact, giving the client or the patient eye contact, let them know that you understand. You may not have experienced the trauma, you may not have been in that situation. However, you understand, try to understand what they're going through. So with that said, I will ask, so any of the panelists, what are healthcare and health disparities present in our communities today? Anyone?
So for me, in terms of healthcare disparities that are present in our healthcare system today, I think it really, for me, interestingly enough, begins in the way that people who work in healthcare are educated. The disparities start even there, in the way that we learn, in the way that our disciplines formulate our assessments, our treatment plans, etc. The theories on which healthcare are based often have in them strong vestiges of healthcare disparities. And so I think it's very important for us to challenge the way that we are trained, to make sure that we are not unwittingly, in our efforts to pass our classes and get that 4.0 and maintain our grades and finish our training and matriculate, that we're not unwittingly beginning the process of at a cellular level, ingesting disparities based on the way that we're trained. So that shows up a lot of times in the way that healthcare is delivered at the bedside, but also it shows up in the way that healthcare is delivered in rooms where patients are not. So when we're building those treatment plans, when we're talking about discharge, when we're talking about how we're building the culture of healthcare, when we are doing those things, we're often violating the principle of nothing about me without me. Mm-hmm. And so the work that we do has to start with the way that we even think about healthcare, to make sure that we are exposing those biases that are built into the ways that we were trained, and to make sure that we're challenging ourselves when we're doing our work, to make sure that the patient really is at the table when we're building the care that we say is good for them, or else we will find that our patients will end up right back at our doors when we miss those disparities in the way that we build the care.
So, Kelsey, do you mind sharing? You have a vast experience from your bio in youth, serving youth with New York Foundling. And so, as someone who worked with, because this is your past experience, with children in the foster care system who I would imagine have gone through, have experienced a lot of trauma in their life, how would you work with them?
Sure. First, I just want to thank Arliss for inviting me to this panel. And I typically don't get intimidated, but I am sitting among greatness. And I'm honored to be here. I just did another panel with Dr. Frontus, and when she speaks, you are going to be blown away. So I'm glad I'm saying this now. I worked in child welfare on the prevention side, on the preventive side, to prevent foster care placements in 2004, so 20 years ago. So I'm really grateful that we're having this conversation, and thank you to Medgar Evers for having this conversation around trauma, because it does not get talked about enough. It certainly wasn't talked about in 2004, when we all knew the disproportionate placements of people of color in foster care, the disproportionate removals of children of color, and all the intersecting systems, broken systems that foster care worked with. And this exacerbated everything and created even healthcare disparities. And so 20 years, I'll tell you, I was in foster care and working with youth then. I spent 14 years in HIV and AIDS. And then I came back to run the Door, a youth development organization, in 2021. And can I tell you, nothing has changed. Nothing has changed because systemic problems require systemic solutions. And out of today's conversations, I hope what will happen is each of us, as social workers, caretakers, policy changers and makers, that we work on a micro level to address the trauma and the re-traumatization that these systems take on us and our clients, and how do we turn that work into a collective action to change systems that must change? Thanks.
Dr. Frontus, you want to pick up on that?
Hi, everyone. Good afternoon, and thanks for setting me up with all this pressure. Now, I'm really honored to be here. I'm a friend here at the college. I came here feeling very nostalgic. I think I was here some years ago attending a very nice girls' empowerment event. I don't know if any of you were there for that. You know, in preparing for today's event, I kind of got lost in the literature a bit because I wanted to sort of push everything out of my head and just think about this topic for today, right? Thinking about trauma and trauma-informed care, thinking about health disparities. And to be clear, we need to do a lot of things today, right? We need to sort of assess the problem. We have to look at it from multiple angles, and we can't leave today without talking about what are we going to do about it, right? And I think for many of us as Black Americans, there's this sort of dance that we do. We talk about communities of color, and then we also need to be specific about the Black experience, right? Like what is happening in Black America. And I wanted to come today to just share a couple of statistics about what is happening on the ground, what is going on. And I'll tell you, if you take just 2 minutes and you go on your phone and you look up any major studies, all of the leading studies that have been published in just the last couple of years have been sounding the alarm. All of our major research institutions, Harvard School of Public Health, it's a who's who of researchers. And they are saying in plain English that being Black is bad for your health. That is a direct quote of a major study that was released by a leading group of researchers. Why are people telling us that being Black is bad for your health? What does that even mean? So the question was asked, what are the healthcare disparities? Well, I'm not a physician, but I definitely do work in promoting, addressing trauma recovery, and I'll talk about that in a bit. But African Americans have higher rates of diabetes, hypertension, heart disease. Black children have a 500% higher death rate from asthma compared to white children. 500% higher. High blood pressure is most prevalent among Black women than all other racial groups. And so not to be too doom and gloom, but we really need to sort of get underneath the surface because we are literally dying from preventable and treatable causes, from lack of education because we're not speaking up. We need more events like this. And you know what I'm going to say when we leave events like this, right? we're not sharing, we're not talking, we're not calling our aunts, we're not calling grandma, we're not having events in our houses of worship. And our communities are literally dying from lack of information. I'm going to stop there because I came with all these statistics, and I'll weave them into my comments throughout today.
Something that wasn't mentioned is, yes, we know that Black and brown people are less likely to have proper access to care. The other thing is the caregivers or the clinicians, a lot of the clinicians does not look like us or the people who they are supposedly treating. So that's something too that we have to also, take into account and be mindful of. And as much as we can is try to legislate and, with policymakers to try to get better policies enacted to treat our Black and brown individuals. Okay. Again, we talked about in trauma-informed care, when I was doing some research as well, there are some strategies that was mentioned in treating someone who has experienced, when you're treating someone who, has experienced trauma. So one of the strategies is to teach clients how and when to use grounding exercises when they feel unsafe or overwhelmed. Another strategy is establish some specific routines in individual groups or family therapy. Example, have an opening ritual or routine when starting and ending the session, because that kind of helps, again, to ground them, help them to, focus and realize that, yes, you can exercise, you can incorporate this into your daily routine to help you overcome or deal with, work through some of the trauma that you have experienced. Another question I have is, and for any of the panelists, how would you correlate healthcare disparities with trauma and re-traumatization prevalent in communities of color? Anyone?
I can start. So we all know that healthcare systems have traumatized communities of color, decades, maybe centuries long. And a few years ago, when we all experienced COVID, and a light was shined on this issue of vaccination and who was taking up vaccinations and who wasn't. And there was a lot of information around communities of color, in particular the Black community, about why the Black community didn't trust the healthcare system. But that was the wrong question. The question that we all should have been talking about is, what did the healthcare system do to engender that mistrust among communities of color? Because when you start with that question, then you'll get to the answer, and then that can lead to the systemic change that is causing the traumatization and the re-traumatization and the further lack of access to healthcare. And until we have that conversation, things won't change. And so I think it's important that we reframe these questions in the right way. But it's not just the healthcare system, it's the foster care system, it's the criminal justice system, it's all of these systems that are continue to re-traumatize our communities of color. And it's going to require, the healing of those scars will require future work with equity and a social justice framework. And that's going to be really important in what we do. And the role that social workers play will be really critical in that.
Mm-hmm. Thank you. I couldn't agree more. And I think also, as someone who has worked in healthcare for a while, one of the interesting things that I experience often is the way that healthcare systems are used by other systems to further systemic agendas. I know we talk about the school to prison pipeline, but there's a hospital to prison pipeline as well that I think doesn't get talked about a lot. But, you know, as a clinical psychologist who specializes in the treatment of children and adolescents, how many times would I get to work and I would see ambulances lined up during the school day? And, you know, they're coming from our schools straight to the hospital. And we know that for every day that a child is hospitalized and they're out of their school setting, it's the equivalent to missing months worth of education. And our average lengths of stay in the hospital for children tend to be around 5 to 15 days. So that's the equivalent of almost an entire school year when you're discharged from the hospital and then you have to re-enter your school setting. And so the cycle sets itself up. I've missed my school environment, even though there is a school in the hospital. It's not the same as being in my neighborhood school. I'm back. The questions about where was I, or even the memory of what led to me being removed from the classroom in the first place. I get back to school, and then I'm back in that disruptive cycle that ends up with me targeted as someone who, or labeled as someone who disrupts the day and has to be removed. And then as the educational cycle plays out between the relationship between being ambulanced to the hospital, admitted, and then being out of your community begins there, it often leads to a path towards being involved with juvenile justice, and then, if you want to call it justice, and then into further incarceration. When I began working at Kings County, I came to Kings County from another health system where the resource allocation was very different. And if you want to talk about disparities, you have to look at the payer mix. How hospitals are funded, how they're able to pull down resources in order to further improvements in healthcare. That's a big part of this. And so when I first got to Kings County, that's where I saw the stark difference between the resource allocation. When you have staff members who would bring their own copy paper because, you know, you don't want to be standing at the copy machine while someone's watching how much paper you use, as simple as that, those things roll up into disparities because the allocation of resources in our communities tend to be different. We have to be so much more creative in order to get things accomplished for our patients, and often the most vulnerable. So I think that there's an intersection there between how healthcare delivers services that we often don't see the connection to larger problems outside of the healthcare system, because healthcare is supposed to be care. And so healthcare systems sometimes get a pass, but I think that healthcare systems are uniquely positioned to disrupt inequities, to disrupt trauma, to disrupt disparities, because everyone in this room is a patient, right? And so we have to really do a lot of our advocacy. There's an opportunity to do a lot of our advocacy within the healthcare space that has far-reaching implications. When you look at the maps of these diseases, preventable diseases that we were just spoken about, they overlay one-to-one with rates of incarceration and places where our family members are missing. Because when you're hospitalized, you're missing from your family too. Right. And the same way the brother talked about earlier, making sure that you are present for your loved one who's incarcerated, be present for your loved one who's in the hospital. The care is very different when they know that the patient has family and people who take care of them.
I think all has been said. But, you know, this is such a great question, and it brought out the philosopher in me, Elaine, because the question is, you know, what is the correlation between disparities and trauma? And I was sitting here thinking it's like a chicken and egg situation, right? Which one came first? Which one came first? All of these things that we've been talking about leads to a sort of racial burden, right? You've heard of the burden of being Black. You've heard of the tax burden, right? There is a racial stress that we have to endure. And so is it the fact that we have been historically marginalized and we have endured that historical trauma that has led to the disparities because we are mistrusting a formal mental health care, not just mental health, formal health care services, because we know that we're not accessing services at the rate that we should? Or is it the other way around? Is it the other way around? Is it because of these figures? Is it because we continue to perish, unfortunately, at a faster rate than all other racial groups in America, that now that has led to the stress, right, and the disparity? So I would say it's a bilateral relationship, and it's just, I'm envisioning it as a circular relationship, if you will, where one is influencing the other. Again, leading causes of death: heart disease, cancer, accidents, high mortality rate, women giving birth. It's just the numbers are obscene. It's really obscene when you compare it. No matter where you are in America, we continue to fare worse, and we really have to get to the heart of it.
Just to piggyback on something that Dr. Wilks mentioned about visiting your loved ones who are in the hospital, the same is also true for those in the nursing homes, because I have a friend of mine who is in a nursing home, and she was not getting the proper care. She had bed sores, they were getting paid. It's not like they're not getting paid, but it's all about, again, reimbursement. So I guess they weren't being reimbursed as much as they thought they should. However, I had to pitch in with her family member to advocate for them to take care of her. You see, because if you don't visit often, if you go once in a while, they figure that they can just do whatever. They don't have to provide the care that the resident needs. So that's something that's very important, to visit your loved ones, or as much as you can, to make sure that the providers see that, yes, they have someone who can advocate on their behalf. So that's very important. Also, again, just to talk about the gaps in service delivery and the quality, again, going back to the hospital patient or nursing home or someone who's incarcerated, because it is very important that, we do have a presence with our family members or our loved ones who are in those situations. Now, another question I have is, have you adjusted in terms of your work when you have someone who is experiencing trauma? Let me ask you the question directly. How have you adjusted your work to combat healthcare disparities and inadequate service delivery? You may have touched on that somewhat, but
So I have a very unique job, right? So I am a clinical psychologist, but as the experience officer, I'm responsible for patient experience and employee engagement or caregiver engagement. And so I get to use my psychology degree for the entire hospital, because clinical work, systems thinking, it shows up everywhere, right? And I think that that's what has been very refreshing at this phase in my career. I thought I would really, really, really miss clinical work, but guess what? It's transferable skills, right? Yeah. And I think that what I've realized, for example, a lot of times, and now I work at some place where a lot of the staff looks like me, a lot of the staff, right? And so, but what I would see, this is how you know it's systemic. Can I talk to you for a second?
Yes.
All right. Yes. When we repeat the systemic problems with people who look like us.
Right.
That's how you know it's systemic, right? So we have an opportunity there because we can be the lab and the proving ground of how you disrupt disparities by doing it in that environment so that we can teach other hospital systems and healthcare systems how it's done. So I would see often that staff would call hospital police for things that did not need policing. But it was because of an underlying trauma. And so we police ourselves at opportunities where there's an opportunity for a compassionate level of communication. And the minute there gets to be friction that the staff member may not know how to address, and that the patient and the family member may be frustrated about, and that frustration may be pushed towards the person that's right in front of them, oftentimes hospital police would be called. And so one of the things that we worked on was the hospital police staff did not like being called for those things. That's not, you talk about working at the top of their license. That's not what they're there to do, right? They didn't want to get into these conflict situations where it could have been resolved with communication, empathic communication. And so one of the things that we worked on is being able to understand that it is traumatizing for a staff member to have the volumes that come through our emergency department and you can't even see the floor, because anywhere we can put a patient, we've put a patient, right? Because we are entrusted to see everyone as the level 1 trauma center, and the volumes of patients coming into the hospital because they don't have access to primary care, and so the ED becomes their PCP. It's not stopping. Right? So we are in the process of right-sizing our hospital to take care of the volumes. But in the meantime, it is frustrating to wait a long time to be seen. And that frustration becomes the context of the discussions that we're having between patient and caregiver. And so a lot of the work of undoing that trauma is to say, leave the police out of this. They don't want to come in and have this discussion. That's not what their role is. That's not what their training is. It's not going to go well.
Exactly.
But let's get on the same side of the problem and the issue. So rather than us seeing each other as us against each other, it's us against the problem. And how can we make sure that the staff's first response is not no, but let's work together to get this clinical interaction to move further towards your goal? Because the truth is that the caregiver, the employee, wants what the patient wants most of the time. And so it's just right-sizing and giving the staff the training that they need to be able to communicate compassionately, to disrupt those disparities and to disrupt those inequities, and understand that the patient is there at their most vulnerable point. So I think that that's a lot of the work, is making sure that we are the lab for how you disrupt those disparities, because we are going to have that disproportionate part of the population that's dealing with these preventable issues. And it means that we have to train our physicians also to understand that Bush tea works. And that when you open the discussion about Bush tea and go lie down, which was, the solve or the panacea for everything, but that rest is recovery. So when you open those conversations and you empower patients to tell you about the Bush tea and about, all the things that they are doing in addition to the pharmacological approaches, that's a way for us to get on the same side of the issue and disrupt disparities in healthcare. I know I said a lot. Sorry.
Can I just say that my mother feels heard because she thinks that she has a T for everything.
Dr. Wills, you must be from the Caribbean.
I'm from Jamaica.
I think we can all relate. I'll keep mine short. I wanted to pull something up, some information that I wanted to share. So, you asked us about the work that we do, and I wanted to share a little experience about a position that I did last year the Jewish Community Council of Greater Coney Island reached out to me and let me know about this wonderful program that the city of New York just implemented. And this might be a little parallel to what you guys are doing at the hospital, but I think a little different. Trauma Recovery Center. So this was an initiative of the Speaker of the New York City Council. Anybody know what I'm talking about? So you know the Speaker, right? Adrienne Adams. She brought some funding to the city, and she kind of brought in this model that was being done in the West Coast, and she liked how it was being done there, and she brought it to New York City. And if you don't know about this, look it up later on, because as we speak, we have at least one trauma recovery center in each borough, but I think that there might be one or two boroughs that have more than one. They might have two, but it's not that many. I think New York City has about 7 altogether. So the trauma recovery centers, it's a nationwide model designated to bring mental health treatment, healthcare, social services, legal resources, et cetera. I worked with the program director to help them launch this program. But what does that have to do with what we're talking about today? Well, it has everything to do in terms of the fact we're talking about trauma, right? And I mentioned this at the other panel that we were on, that I do see myself sometimes as sort of like a one-woman ambassador on a mission by myself. I don't need a team, and I'm just out there letting people know that we have to get healed. We have to prioritize our health and wellness, and we have to tell this to everybody that we love. We're working ourselves to death, and we're walking around with untreated trauma. In every single household in our community, someone has experienced something that would pass the litmus test for trauma, for the definition of trauma. Whether that person is a survivor of sexual assault, by the way, experiencing racial discrimination, right? Systematic barriers, gun violence and gun trauma, which we experience a lot in our neck of the woods. If you're born and raised in Brooklyn, we're not even talking about that. We're literally not even talking about the way that we're living under gun violence every day, 7 days a week, hearing gunshots, dodging bullets, worrying about our well-being, praying that our kids get home safely. Just the stress of living in this city with all of the things that are going on. Ladies and gentlemen, that is trauma. And so the question is, where are we going for healing? And how are we getting connected to the services that we need? So if I do nothing today, I just want to quickly share all those little tidbits of information, because we all need to be those personal ambassadors. We should know where our local trauma recovery center is. We should know where our local mental health clinic is so that we can be referring our friends and family.
Thanks. And I have 3 things. If we're going to try to address healthcare disparities, we need to address the trauma. And if we're going to address the inadequate service delivery, we need to reframe what we do. And so I'm a social worker, so I'm allowed to say this. I think sometimes social workers get it wrong. Our field is based on deficits. We identify the deficit and then we try to fix somebody. And I think that's just the wrong approach. And this speaks to trauma. So understanding that people have experienced trauma. Does anybody raise plants or a garden here? Okay, I don't, but I've heard. Trust me, I don't. I can't even keep a cactus alive. But what I've heard is that when your plant doesn't grow or thrive, you do things like change the soil, water it differently, position it differently against the light. So when a person or child doesn't grow or thrive, why do we look at the person and not their environment? Maybe it's their setting, maybe it's their family, maybe it's a system that's trying to help them. And so I think if we reframe that, we have a better chance of providing adequate and culturally competent and culturally humble care. The second thing is, one of the principles of trauma-informed care is choice and power. And I think you said nothing about me without me.
Right.
I've learned it in the HIV, feel nothing about us without us. And so we talk about that. Schools of social work talk about anti-oppressive practice. There are many ways to approach it, but so many different systems are talking about it, yet it's still not being done in the agencies that we work for or work at. And so one of the things we've done at the door is we are trying really hard to be very conscious about making sure that we involve the young peoples. We call the people that we serve, we call them young people. I would like to be categorized as a young person, but the people that we serve, the young people at the door, we try to include them in as many choices, as many decisions as we make. As a CEO, I try to involve as many staff people in the decisions that I make. I think it was Professor Richardson that said, our assessment tools don't match, don't work for our communities. So asking the young people, do these questions make sense to you? If you were a new person, think back a year ago when you first came to the door, how are these questions? Does this get to the heart of why you're coming here? We have a new intake assessment form. It is way more effective because we did that. And the third thing is, I think you talked about it. If we're going to deal with trauma with our clients, we have to understand the trauma that our staff are facing. We experience healthcare disparities ourselves. We experience COVID, we experience race-based violence. And how can we expect our staff to take care of other people if we're not taking care of themselves? Or if we're not taking care of them and we're not helping them take care of themselves? I think that is really important in making sure that we can continue to uplift our communities, starting with our staff and our teams first.
Ms. Delmage in her presentation talked about funding. So, we still have to, I guess, to go by whatever the funding is for our program. So we have to adhere to that. So if we see that in our work with the clients that they need more services or it's not working, we still have to abide by some of the, by our funding source. So how do we deal with that?
I have a quick suggestion. A lot of the times when you're working with a funder or a donor, you create a power imbalance. You stand here and you put them here. And we do that to ourselves. And we need to think, I don't know that we can do this, but we can do this. And we can tell our funders and donors that the things that they've decided for us, by the way, aren't effective. So let us partner. We don't have to do this, but let us partner. Let us tell you what we're experiencing. Let us tell you, please ask us what we think the money should be used for. And I tell you, I've done it several times and it works. And it does work. You have to find the right partner. Of course, you need a funder and a donor that's willing to hear, but you can test it out, but it can happen. And until we do it more and more often, funders will continue to stay here when we're here.
Because they're not doing the work, so they really don't understand what some of our clients are going through.
Okay.
So how we have to work with them to help our clients thrive, survive, or function in a day-to-day life.
Yeah, and I found that one thing, COVID taught me a lot of things. But one thing COVID taught me was that the money is out there, and that a lot of things that we thought we could not do can be done and can be done today. And so I think that we don't want to lose that creativity. We don't want to lose that empowerment. We want to continue to build on those relationships that we established then, because the public healthcare system is uniquely positioned to solve problems in a creative way. And when we have the right funding at the right time in the right space, we are able to do so much more. And we are able to show the value add that we do have to the philanthropists and the donors their mission, because we're not going to waste your money. That's one thing you can count on, because we already know right now how much money we need to put up a structure at our hospital that would adequately serve the community that we're in. We know the number today. We know how much to ask for. We know exactly what it is. And we're no longer playing small, and we're making sure that we continue to build on those relationships of those donors who we got their attention during COVID, and we're seeing great results as a result of that. So it's about staying plugged in. It's about continuing to show that we bring value to be able to not only do the work, which we're very good at, as Dr. Delmage, my colleague at Kings County, and I know for a fact, it's not only to do the work, which we do day in and day out, but to also write about it, to tell about it, to make sure that the storytelling about what we're doing that is so effective is not left to other people, so that we're telling the stories as well. So we're able to make sure we get that funding and that it's used wisely in a fiscally responsible way, down to the dollar, for the communities that we serve. So we're really excited about what we're doing there. And we also welcome other ideas. We have a very active Patient Family Advisory Council at Kings County, which partners with not only patients and families, but also frontline staff, managers, and senior leaders. That's how we found out that certain programs were being closed from our patients' mouths themselves that we didn't even know about. And we were able to remove the barrier to that prevents those programs from closing, so that those services that the community find valuable can be funded and can continue to bring the care that they need to the communities that need it the most.
I'm told that we have 1 minute. Time flies when you're having fun, right?
I don't need a minute. I'll just say ditto to what the two great panelists said. I mean, it's, ladies and gentlemen, we are partners. We're partners with funders. We are experts on what is going on. You know, when I look at the community work that I've done over the years in my own neighborhood where I live, where a proposal that I'm writing about, you know, I have experienced myself. It's very, very important that we, with humility and professionalism, you know, always have that open relationship with our funders to let them know what's happening on the ground. And we'll get it done. Thank you.
So I don't even get any perks as a former professor of Harley. She told me that there's no time for Q&A. Sorry about that. I just want to thank the panelists, Mr. Kelsey, Dr. Frontus, and Dr. Wilks, for your participation. It was very informative, very enlightening. Thank you so much.
So y'all, remember I was saying that we wouldn't have a field department without Professor Reid, who was the first one to put me on to We May Be Small, but we are Tulawa? We wouldn't have a department, yes now. We wouldn't have a department if we didn't have a chair. Social work faculty, would y'all stand? Yes. We present to you, Dr. Hernandez, an award of appreciation. Ida started the program, you stepped in, you anchored us as we made it through the COVID quarantine, and Lord knows, thank you for picking up your phone all them times. Thank you so much on behalf of the faculty of the Social Work Department. Dr. Ed Hernandez, y'all.
Now I'm gonna cry. Thank you, but I couldn't do it without all of you. You know, it's a team, it's not just me. So thank you all for everything you do as well. And thank you all the students for all you do, and taking your education, going to grad school, and representing Medgar out there. And we have a great reputation both in our grad schools, where they come every year to recruit our students, and a lot of you are doing very well out there as social workers, making us proud. Thank you all.
Thank you.
Okay, ladies and gentlemen, I am deeply honored to close this 17th annual Medgar Evers College Social Work Conference. And it is with a profound sense of gratitude that I extend heartfelt thanks on behalf of this year's committee to each and every one of you, whether you're here in person or virtually. To our esteemed speakers, your expertise and vision have challenged us to rethink our approaches and reaffirm the importance of our collective work efforts in effecting positive changes in our society. To the panelists and moderators, your participation has enriched our discussions and provided invaluable insights into the pressing issues facing our communities today. The work we do as social workers extends far beyond the confines of today's conference, and it is through continued dialogue and action that we can make lasting differences in the lives of those we serve. Thanks to the actions and commitment of committee members Mathylde and Sherry, for the second consecutive year, they have made it possible for CUs to be offered to attendees. In closing, I reiterate our gratitude to all attendees and contributors, especially to those who have worked tirelessly behind the scenes to ensure the smooth execution of this conference. May we carry the spirit of empowerment and advocacy as we embark the next chapter. And now, may we stand together and demonstrate our commitment to all of today's manifestation through a pledge. And you do have it in your program, so don't let me do it alone. This pledge was written by Dr. Kimberly Moore. Today, we celebrate the profession of social work. Our commitment to social justice, service, and love. Today, we celebrate the profession of social work. Go ahead. Strengthening and uplifting the voices of the silence with our heads and hearts seeking guidance from above. Today, we celebrate the profession of social work through the active practice of health promotion and advocacy, calling for equity and equality, demanding fairness and access for services of quality. Today, we celebrate the profession of social work as we readjust our lens, our clarity and discernment to mend. Today, we celebrate the profession of social work, using ourselves as vessels for change through every specialty, discipline, and methodology. We deserve an increased wage. Today, we celebrate the profession of social work. You'll find us everywhere. We are sought out for information, empathy, comfort, and care. Today, we celebrate the profession of social work. We are empowered now